Okay, good morning, everyone. Nice to be with you, and I apologize for my voice today. Um, I'll be presenting on A5-D2, participant health history, and clinician-assessed medical conditions. So in UDS version 3, there were two separate forms which got at medical history, and those were A5, health history, and D2, clinician-assessed medical conditions. The distinction between the two in UDS3 was that A5 was based on history obtained from the participant or the co-participant, and D2 was based on the clinician impression after they had conducted their full UDS visit. However, for UDS version 4, these have been combined into a single form, which is called A5-D2, Participant Health History Clinician Assessed Medical Conditions. And thus, on this form, we should capture conditions which are identified on the health history interview, as well as review of medical records, as well as after your neurologic exam with the participant and session with the participant. And it is important to know that we want to capture the best and most accurate information possible about the participant's medical history. So that should include an interview with participant and co-participant, review of medical records. And that is important to realize because that it may be the case that certain of our centers, IRBs, do not typically review medical or allow review of medical records, or that's not part of our workflow. But that would be something to work towards so that we could capture accurate medical history information. So this is to show from UDS version 3, this was A5, our subject health history form, and this was D2, our clinician assessed medical conditions. And now they have been combined here into form A5-D2. Again, the header is the same on all of our forms, which include language, mode of data collection, and certainly this form could be captured remotely before the visit or by telephone. However, the form is rather complex and would not be very well suited for a participant to complete themselves. Again, just to show, we've clarified that what the data sources are, including the interview and the review of medical records, and then any conditions identified during the visit should be included on the form as well. The coding guidebook provides a lot of help for this form. So what's new on this form? So much of the form will be familiar with more detailed questions about specific conditions, as well as some new conditions that have been added. There's more detailed information collected about traumatic brain injury, including risk factors for traumatic brain injury. There's more detailed information to be collected about cancer history and treatment. Psychiatric conditions should be based when coded on the DSM-5-TR criteria, and new information will be collected about menstrual and reproductive health. So let's go through the form and look at a couple of the new spots here. So in UDS version 3, we did ask about alcohol use. The question previously said in the past 3 months, and now we're asking in the past 12 months, how often has the participant had a drink containing alcohol? And this was to align with the substance use question. And then there was a question added here in UDS version 4. In the past 12 months, how often did the participant have 6 or more drinks containing alcohol in one day? And this is to get at the potential for binge drinking. In the substance use question, there was a question added, 1J, which specifically gets at any use of cannabis or marijuana. And that's in the past 12 months, how often has the participant consumed cannabis, edibles, smoked, or vaporized? And this question does not get at cannabis use, which causes significant impairment in one or more of the following areas of life. 1J specifically is asking about any use of cannabis and to quantify how often that is. Then when we get into the meat of the form, we are coding conditions in a similar way in UDS version 3. So conditions are coded as absent if they've never been present, recent or active if they happened within the last year or still require active management, remote or inactive if they occurred or existed in the past more than a year ago, but was resolved or there is no treatment currently underway, or unknown, there is insufficient information available about a condition. And then this applies through the remainder of the questions. So we had previously asked about stroke, and here we added an additional question about the status of stroke recovery in 3A3. What is the status of stroke symptoms? Never improved, partially improved, improved back to normal, or unknown. And this may end up tying in a bit with the neuroexam findings. There were some more details added to questions about seizure history. So the initial question is about epilepsy and or history of seizures, excluding childhood febrile seizures, whether they're absent, recent active, remote inactive, or unknown. And previously we left it at that, but we've added 2 questions, which are getting at seizure control. So 4C1, how many seizures has the participant had in the past 12 months? And here are the choices. And 4C2, the age at first seizure, excluding childhood febrile seizures. And this is to get at the chronicity of the seizures. So the section on repetitive head impacts and TBI has certainly been expanded and fleshed out. Here is the section from UDS version 3, which asked about traumatic brain injury, and then classified as TBI with brief loss of consciousness, extended without loss of consciousness in year of most recent TBI. And here is how it's been laid out for UDS version 4. So the first question is about whether the participant has a history of repetitive head impacts, e.g. from contact sports, intimate partner violence, or military duty, regardless of whether it caused symptoms. And the choices are no, yes, or unknown. And then the source and the total length of time that the participant was exposed to repeated hits to the head. And this is getting at recent research which identifies that individuals may not need severe head trauma or even symptomatic or clinical concussions to increase their risk of CTE. After this section is completed about the repetitive impacts history, we go into the symptomatic head injuries. So we need to code yes or no if the participant has a history of head injury that was symptomatic. So a head injury that resulted in a period of feeling dazed or confused, being unable to recall details of the injury, for example, amnesia, or loss of consciousness. And if multiple head injuries, consider them most severe. So no or yes. Next question is about what was the longest period of time the participant was unconscious, the longest period of time the participant was dazed or confused, the total number of head injuries that were symptomatic, the age of the first head injury, and the age of the most recent head injury. And we think that these questions really flesh out the TBI and head injury history for our participants. A little bit was added here about diabetes in section 5A. So diabetes is queried, whether it's absent, recent active, remote or inactive, or unknown, which type. And then we've added some questions about the treatment given for diabetes, including several standard treatments as well as the new GLP-1 receptor activators. And then we've also added the age at diabetes diagnosis to get at the chronicity of diabetes history. Question 5I, sleep apnea was present in UDS version 3, but we've added questions about the typical use of breathing machine CPAP, the number of hours per night over the past 12 months, as well as any use of any other treatment for sleep apnea, like an oral device or implanted breathing pacemaker. And this is, again, to get at whether the sleep apnea is being adequately treated. Additions were made to recording cancer history. Again, cancer history can be listed as absent, recent active, or remote inactive or unknown. Cancer should be coded as primary non-metastatic or metastatic, and we've added the choice of metastatic to the brain. And again, more than one can be checked here. Check the primary site of cancer and the type of cancer treatment and the age of the most recent cancer diagnosis. This form may get complex if participant has more than one type of cancer. And in that case, the researcher should code all that apply. Continuing in section 5, we've added broader and deeper coverage of medical conditions, including adding COVID-19 infection, adding chronic kidney and liver disease, peripheral vascular disease, and HIV. For psychiatric conditions, many of these were present previously in UDS version 3, but we call out that the researcher should be using DSM-5 criteria for coding these in the health history section of the UDS. And then finally, we've added a section on menstrual and reproductive health, which is new. And hopefully this is fairly straightforward, asking about how old was the participant when they had their first menstrual period and their last, the status of their menopause, or the mechanism of their menopause, their use of female hormone replacement pills or patches. And this question excludes creams or suppositories. And has the participant ever taken birth control pills? And this was a section which really wasn't present at all in UDS version 3, so it's really been fleshed out here. So in summary, from UDS version 3, the A5 health history and D2 clinician assessed medical conditions have been combined into a single form, which is called A5-D2, participant health history clinician assessed medical conditions. A5-D2 is to be completed by the clinician or ADRC staff based on the medical history interview with the participant and co-participant, as well as review of any medical records that are available. And these forms include broader and deeper data collection about health history, including topics in neurologic, medical, psychiatric, and reproductive health. Thank you very much.
Do we have time for questions, Hannah?
Yes, we have about 6 minutes.
Okay, great. So Aimee, there's a lot of questions in the chat, but one, and I can't remember what we had decided, but the cannabis question, is that to include both CBD products and THC? So again, you know, a lot of clinicians note that most people are using the CBD more than THC. Looks like
Good question. I can't quite remember either. I've got the coding guidebook here, so I'll pull it up while we go to the next one.
Yeah. That's what I think we'll clarify this. And this is one thing that we do want people to make comments on, so we can clarify in the coding guidebook to guide people. So the questions are pretty set, but the coding guidebook, we can give more clarification. So I'll have Aimee look at that.
Yeah, I don't think it says either way in the coding guidebook right now.
It doesn't say that either way. Okay. So we will work on clarifying that, though. But that's a good point that's been brought up. Thank you. We didn't have details on cannabis use prior, but a lot of us are recognizing it. It's more common. And then there's a question on section 4G about the blast injury. So military blast, should that be considered a head impact for this form?
So, yes. So essentially, a military blast injury, military blast impact would be considered a head injury if there was any symptoms. So that question about head injury gets at whether there were any symptoms at all. And so if that military blast caused symptoms, then it would be coded there.
And there were some questions too, some really good questions. So again, with the Spanish, so there will be a Spanish version of UDS4 and a Chinese version. But I think the timing, I don't know if anyone from NACC can speak to, again, there'll be a lag behind with the English because we have to finalize the English and the code book before moving to the translation. So someone from NACC have that time frame handy?
I don't think that there have been like specific dates set. It's going to be after the English versions, like you said, and I think Spanish will come before the Chinese version. But yes, there will be a lag so that you can keep collecting UDS3 data for participants who speak Spanish or Chinese while we wait for the translations to be ready.
Thank you. And then there's some questions about the impact or the for psychiatric conditions if we're using DSM criteria on these forms or if this is patient self-report.
So I think it'd be great to hear from Costas or anybody else from the CTF, but my opinion is that these forms allow us to make a new diagnosis for patients and to code a new diagnosis for patients. And so if we are coding a new diagnosis, then we should be using the DSM-5. However, if we do medical record review and we hear and we can see when the person is being treated by a psychiatrist on antidepressants, then I think that that is good enough for coding it as a psychiatric condition here, as long as we have every reason to think that these are, good and reputable health professionals. But wonder what you think about that, Costas.
Yeah, the forms do have the DSM-5 TR criteria noted next to them. So go ahead, Costas.
Yeah, I think the point is if we believe a psychiatric disorder is present and contributing etiologically, we need to define that in a way that's consistent across the centers. And the DSM is the way that's done. As far as I know, there is no other classification. The risk of not using DSM-4 is that we would have variable, idiosyncratic, and consistent diagnoses that we couldn't really put great faith into. In terms of deciding whether someone meets DSM criteria, I think, Aimee, you're right. It's not a very difficult thing. I would suggest that people just look at the criteria for 2 or 3 of the common conditions and think through about whether it's met. Major depression might be the more complicated one, but there are other DSM diagnoses for a depressive disorder that doesn't quite meet criteria for major depression. So there are options, and it's not terribly difficult. So I would encourage people to have a look. And Aimee, I agree with you. If a colleague who's a professional in the area has been diagnosing and treating someone as such, yeah, I would trust that, unless it's me, of course.
And Costas, do you want to speak to the there's several questions about how how that will be implemented. I think we've talked before about training, having someone from people's teams train them and how to use this DSM criteria, and also just a reminder that there are great resources online from our own Costas Legatsos going through about using these diagnostic criteria. But I don't know if you want to speak to that, Costas, a little bit.
Well, I am open to doing a webinar to walk people through what the criteria mean for a select number. Obviously, we can do it for anything, but maybe NACC could help guide us on what they think are the most common diagnoses that would be relevant here. And then I'd be happy to do a webinar to walk people through what the criteria mean and how to confirm whether someone meets criteria. Probably enough to do it over 2 or 3 diagnoses, because a lot of the concepts carry over to pretty much everything else.